The first speaker up is Jordan Stern, who will be talking about his WEWIRE technique. Jordan, with much ado.
Hello, I'm Jordan Stern. I'm a vascular surgeon at Stanford University, and on behalf of my co-authors, Drs. Connolly and Meltzer, I'd like to thank the VESS for the opportunity to present this today. I hope you'll find this to be a novel and interesting technique. We have no disclosures relevant to the content of this presentation. Peripheral arterial disease often presents in a multi-level fashion. Infrainguinal PAD is most commonly managed by a variety of either endovascular or open techniques, while iliac disease is generally managed with either percutaneous angioplasty or stenting. However, when multi-level PAD involves the common femoral segment, this presents unique challenges. As we know, common femoral artery is not an ideal spot for endovascular interventions due to issues related to hip flexion and coverage of the profunda femoris. The common femoral is most commonly dealt with using an open endarterectomy technique, and this may be combined with either bypass or endovascular approaches to address multi-level disease involving the common femoral segment. Hybrid interventions involving the common femoral have been described a number of times, and over time have demonstrated both high technical success as well as durable results, even in multi-level reconstructions. The traditional approach to hybrid interventions involving the common femoral artery involves an open approach to endarterectomy of the common femoral first, followed then by patch access and endovascular interventions either in the SFA or the iliac inflow disease. Problems can arise related to distal reentry in either of the adjacent vascular beds. There are additional issues that may arise related to access sites and controlling the patch arteriotomy. We propose here a novel technique that uses retrograde access, which prevents some of these issues, particularly related to the endpoint, and simplifies management. The REWIRE technique, or retrograde endovascular with intimal reentry through endarterectomy, combines open femoral endarterectomy with endovascular intervention of the femoral popliteal segment. Endovascular crossing is via retrograde access with reentry into the endarterectomized segment of the common femoral artery, which mitigates some of the issues related to reentry. The technique begins with retrograde access obtained via a patent pedal, tibial, or popliteal artery. The wire is then advanced across the occluded segment in a subintimal plane to the level of the common femoral artery as visualized on fluoroscopy. In our practice, we generally use the femoral head as a marker for this. Next, open surgical exposure of the common femoral artery proceeds in the standard fashion, and endarterectomy is performed after clamping. During endarterectomy, the wire is easily found in the subintimal plane in the endarterectomized bed and externalized through the patch. Following this, the sheath is then inserted backwards over the wire, the patch is completed, and the clamps released, reestablishing flow to the lower extremity. With through-wire access now established, endovascular intervention performed as desired in the superficial femoral to femoral popliteal segment. This intervention can be performed either from the femoral sheath above or from the pedal sheath below. Once the intervention is completed, the wire and sheath are removed, the patch access site is sutured, and the pedal access site is controlled as desired by the individual operator. We've now completed this procedure in 7 patients, all with long segment occlusions of the SFA with concomitant need for a common femoral endarterectomy. All patients presenting to our clinics have been CLTI patients. Retrograde access was obtained in 4 patients via anterior or posterior tibial arteries, 1 patient by popliteal access, and 2 patients in the distal SFA. Common femoral artery was performed with bovine patch angioplasty in all cases. The access site distally was managed by manual pressure in the 4 tibial access sites and by placement of a covered stent from above in the popliteal and SFA access sites. Technical success, meaning the ability to complete the endarterectomy and revascularize the adjacent segment, was achieved in 100% of cases. 30-day freedom from adverse limb events was 100%. Hybrid revascularization involving the common femoral artery is well described, but it involves major issues regarding reentry. When reentry is desired in the distal SFA and popliteal, it can be difficult to reenter from the subintimal plane, and when the section plane is extended distally, this may actually compromise distal bypass targets. When retrograde access is performed, crossing the lesion is often much easier, but dissecting the common femoral can put the profunda femoris at risk and can extend the disease far too proximally. This REWIRE technique allows retrograde reentry into the endarterectomized segment of the common femoral artery, which mitigates the risk of propagating more proximally. There's no need for reentry device or any other tricks that the endovascular operator may generally use for reentry when it becomes difficult. Finally, the profunda femoris can be protected under direct vision without any risk of compromise of flow. One advantage to this is that it uses standard techniques and standard devices that are all familiar to us. However, the technique does require some comfort with retrograde access and crossing techniques from below. Once again, management of the retrograde access site is required, and this again would default to the operator's primary practice when using pedal access in general. The procedure, although generally performed in femoral popliteal revascularizations in this series, could easily be adapted to iliofemoral hybrid procedures with access via the common femoral artery on the contralateral side or via upper extremity access to cross the iliac disease. In conclusions, REWIRE provides an alternate method for hybrid revascularization involving the common femoral artery. Direct reentry into the endarterectomized common femoral eliminates many issues related to reentry and propagation of the subintimal plane. And finally, the profunda femoris can be protected under direct vision. Thus far, we've only treated a small number of patients with this method, but it could be easily applied to others. We've achieved good technical and short-term results, and we would expect the durability to be similar to a standard hybrid approach, as the end result is basically the same. Thanks very much. I look forward to any questions you have, and hopefully you can find this useful and applicable to your own practices.
Thank you, Dr. Stern. That was very, very interesting. I have a question. How do you manage the proximal superficial femoral artery in this case? Are you accessing this patch sort of, more proximal, closer to the external iliac artery to kind of nail that proximal superficial femoral artery? How are you managing that?
Yeah, so that's a good question, Karan. Thanks for that. Generally, I would extend my endarterectomy onto the proximal SFA, and then kind of leave almost like a cord out stump there, so that you can cross when you come backwards into, which actually sort of ends up being the proximal SFA rather than the common femoral. And then you do need some running room for the sheath, which I think is what you're getting at. So then I would externalize it through the proximal portion of the patch, which is generally up sort of closer to the epigastric branch and things like that. What I usually do is kind of make a little poke hole in the patch with an 11 blade and then pass the wire back through that and then backwards over that, put the sheath in, and it sort of allows you some room. The other thing that you can do, because you have an open groin, is you can kind of back the sheath out part of the way to be able to get that proximal SFA disease.
Thanks, Jordan. There's a question from Dr. Amendola. Do you commonly use sutures to tack down disease in the common femoral artery? And second part of this is, have you ever re-entered at the junction of the profunda? And if so, how was it handled?
So that's a good question. Thanks, Dr. Amendola. I generally, when I'm doing an endarterectomy, may use a tacking suture or two at the profunda origin if I'm really worried about a dissection flap propagating downwards, because obviously that's sort of the money of the common femoral endarterectomy in general. With regard to re-entering at the profunda, I think one of the big advantages of this is, again, if you sort of endarterectomize a little bit onto the SFA, when your wire comes backwards, it enters the endarterectomy plane wherever you've stopped the endarterectomy, right? Because that sort of is the subintimal plane that you've developed from below with the wire. So there's really no issue with intruding on the profunda with this method. I think if you're going to do retrograde access without an open common femoral, then there's a real risk of propagating that dissection, the dissection plane proximally, and then compromising the flow in the profunda.
Jordan, along the same lines, why not? I mean, if you have a flush occlusion of the SFA, you could probably utilize this technique for that as well. I mean, you could potentially, get retrograde access. You can make a small incision over the common femoral, dig out your SFA, do an endarterectomy, and retrograde stent that.
Yeah, even if you don't have to do a common femoral endarterectomy, I think is what you're getting at, right? You don't really have to do a proper endarterectomy, but at least you have control and you can see exactly where you've re-entered. You do, if you're going to really take advantage of this, you do have to do the endarterectomy, at least part of it, to allow the re-entry there. But you could sort of adapt it to that situation.
Right, but once again, you can go up and over. You can identify the orifice of the SFA, right? I mean, you could do, you can sort of just cut down on that segment, clamp the common, protect the profunda, endarterectomize that proximal SFA, and then stick the common, and then you could do the same technique, and you can, kind of deploy a stent right there. I mean, you could bareback a stent if needed for that area.
Yeah, you could do that for sure. The point is basically to mitigate the risk of reentry and propagating either proximally or distally, depending on which way you're going. So you can. There's actually a lot of ways that you can adapt this.
All right, thank you very much, Jordan. Very interesting. I will pass along to Dr. Wu for the next introduction.
Thanks.